morning, and welcome to the Cardiology Perspectives, dedicated to a discussion of the management of cholesterol. I'm Dr. John Kane. I'm joined here in the studio by Dr. Thomas Bersot, Dr. Stephen Young, and Dr. Alan Chait. This morning we're going to have a series of technical presentations on various topics in cardiology. The first of these will be a discussion of the National Cholesterol Education Program guidelines.
Welcome to Cholesterol Consciousness, a presentation of the new adult guidelines for management of high blood cholesterol from the National Cholesterol Education Program. I'm your host, Dr. Larry Grouse. To review key points of ATP2, I spoke with Dr. Scott Grundy, the chairman, Dr. James Kleeman, the coordinator of the National Cholesterol Education Program, and Dr. Basil Rifkind, the chief of NHLBI's Lipid Metabolism Atherogenesis Branch.
One of the major points, it's emphasized in the adult treatment panel's first report, but it's highlighted in the second report of the panel, is the emphasis on what we call secondary prevention, reducing cholesterol in individuals who already have coronary heart disease. The report virtually says that all such individuals are candidates for cholesterol lowering and sets new and ambitious goals for the target levels of LDL cholesterol.
A third new feature is that with respect to dietary therapy, which is still the mainstay of treatment in ATP2 as it was in ATP1, physical activity and weight loss in the overweight now receive considerably more emphasis. So in a sense, dietary therapy now has three elements. It's the composition of the diet, it's the physical activity, and it's weight loss in the overweight, and they all make a difference. The classification of cholesterol levels is as follows. A total cholesterol under 200 milligrams per deciliter is termed desirable blood cholesterol. A total cholesterol 200 to 239 milligrams per deciliter is called borderline high blood cholesterol. And a total cholesterol of 240 milligrams per deciliter or above is called high blood cholesterol. In addition, an HDL cholesterol under 35 milligrams per deciliter is called low HDL cholesterol.
The risk factors that come into play when we decide on whether to lower LDL cholesterol in an aggressive way are age, and that includes men over age 45 and women over age 55, then premature coronary heart, a family history of premature coronary heart disease, smoking, hypertension, low HDL cholesterol, HDL below 35, and diabetes.
When should drug therapy be considered after intensive dietary therapy has proved inadequate?
If the LDL is above 190 and there are no other coincident problems such as other risk factors, then one would consider adding drug therapy to the dietary regimen. If the LDL cholesterol sticks above 160 after diet and there are two other risk factors for coronary disease, then again one would consider drug therapy.
In the patient with coronary disease, if that patient has an LDL cholesterol level greater than 100 milligrams per deciliter, diet treatment should be initiated. And the goal in that patient is to get the LDL under or at 100 milligrams per deciliter. If that patient has an LDL cholesterol level greater than or equal to 130 milligrams per deciliter, even after adequate and intensive dietary therapy, then drug treatment should be considered with the goal of getting the LDL cholesterol to about 100 milligrams per deciliter also. If the patient has, after dietary therapy, an LDL cholesterol between 100 and 130 milligrams per deciliter, then obviously clinical judgment is going to have to be used to decide whether drug treatment is appropriate in that patient. I think the crucial clinical messages are, first, that all adults 20 years of age and older should have their total and HDL cholesterol measured in the non-fasting state at least once every 5 years. The physician should regard the patient's overall risk of coronary disease in deciding how intensively cholesterol-lowering therapy should be pursued. It's dietary therapy that should constitute the mainstay of treatment, together with weight loss in the overweight and an appropriate regimen of physical activity. And finally, drug treatment should be reserved for high-risk patients.
Our thanks to Drs. Grundy, Kleeman, and Rifkind. Now that we've seen the overall structure of the guidelines, let's hear about the actual therapies we have to offer and how to use them. Dr. Alan Chait, a member of the ATP2 panel, what's your approach to the use of medications in patients in whom dietary therapy has failed?
If diet therapy has failed in a patient who's at high risk, who still has not achieved their target LDL cholesterol level, one definitely has to consider drug therapy. One should reserve drug therapy for those individuals at the highest risk. In other words, people with established coronary artery disease, with multiple risk factors, or with genetic forms of hyperlipidemia which are associated with very high cardiovascular disease risk and with very high LDL levels. These are the individuals who are most likely to benefit from drug therapy. The drug that one chooses is going to, again, vary. One's got to put into the equation many different factors. For example, if the triglycerides are elevated concurrently, or if the HDL is reduced, one would like to use a drug that is likely to reduce triglycerides and increase HDL in addition to lowering LDL. Such a drug would be niacin. One also has to consider the degree of cholesterol lowering. The reductase inhibitors are particularly good at bringing cholesterol levels down. Therefore, if the level of LDL cholesterol level is very much higher than the target level you're trying to achieve, the use of a reductase inhibitor alone or in combination might be the drug of choice. The bile acid sequestrants are good drugs, they're safe drugs, they've been used for a long period of time. I would think that their best use would either be in combination, where one can use low-dose bile acid resins, which are much easier to comply with, or in young individuals who are likely to be on drug therapy for a long period of time, and because of their relatively low toxicity, they would be appropriate choices. All of the cholesterol-lowering drugs have side effects. Therefore, if a patient is started on a cholesterol-lowering drug, it's imperative to monitor them at frequent intervals to make sure that they're not getting any of the well-described side effects. These side effects tend to be reversible. Therefore, if one detects them, it is fairly easy to either lower the drug or change the patient to another drug and therefore avoid these side effects. But the most important thing is patients do need to be followed up regularly, looking for the specific side effects of each of the cholesterol-lowering drugs.
How do you approach elevated triglyceride levels?
Triglycerides are more difficult. Not everybody with an increased level of triglycerides is at increased cardiovascular risk. Therefore, it's important to try and ascertain whether the patient with hypertriglyceridemia has a positive family history, has diabetes, chronic renal disease, or the central obesity syndrome, in which case they're likely to be at increased risk. Another thing about triglycerides which makes them a little different to cholesterol and LDL cholesterol is that the absolute number doesn't seem to correlate with the risk.
We thank our faculty members for their perspective. This program has been an overview of the second Adult Treatment Panel report.